Everybody, and welcome to our session this afternoon of Live MDD. My name is Dan Dilling. I'm a professor of medicine at Loyola University Chicago and work on the interstitial lung disease team there. I have some folks with me. I think they're off camera, but you'll be hearing their voices and then seeing their faces as we go through it and as we get into live discussion. First, I'd like to introduce Lida Hariri. She's an assistant professor in the Department of Pathology at Harvard Medical School and at Massachusetts General Hospital. We also have Stephen Hobbs. He's an associate professor of radiology and medicine and the chief of cardiovascular and thoracic radiology at the University of Kentucky. Next, I will introduce Elizabeth Volkman. She's a rheumatologist and director of UCLA's scleroderma program and co-director of the CTD ILD program there at the David Geffen School of Medicine. And lastly, Teja Kulkarni, who's an assistant professor at University of Alabama, Birmingham, and leads the ILD program there as a pulmonologist. So thanks everybody for joining us, and it's going to be a really fun and interactive session. And why don't we get started by talking through a case by Dr. Volkman.
Hi, everyone. Thank you for the lovely introduction. I'm delighted to be here today and present to you a case on SSc-ILD, which I feel like highlights the importance of screening and monitoring patients with connective tissue disease for the presence of ILD. So we'll jump right into the case. And this is a 39-year-old Caucasian woman who in 2009 reported the development of Raynaud phenomenon, so color changes in her hand when exposed to cold or stress. A year later, she developed disabling fatigue. And then by 2013, she had developed severe shortness of breath, and she was working as a nurse at the time, and she actually had to stop working because she had so much shortness of breath on exertion. And she saw one of her colleagues at the hospital where she worked in cardiology, and they decided to do a right heart catheterization, and she was found to have pretty significant pulmonary hypertension. Her mean PAP was 56, and they started her on tadalafil. She also underwent further workup with the CTA of the chest that was negative for PE, and also the report said negative for interstitial lung disease. But by the following year, her shortness of breath really wasn't getting much better. So macitentan was added on to the tadalafil for her regimen for pulmonary hypertension. But in the same year, she started to notice telangiectasias on her face and her chest. And then a year after that, she developed symptoms of reflux, and she modified her diet to try to help with those symptoms. But being a nurse and being medically savvy, she decided to refer herself to UCLA Rheumatology. She was concerned that she could have scleroderma. So I saw this patient in 2016, and when I saw her, she had very faint bibasilar crackles on exam. She not only had telangiectasias on her face and chest, but she also had them on her upper palate and the palms of her hands. She had sclerodactyly, which is basically thickening of the skin of the fingers, and a modified Rodin skin score of 2. And this is the way that we quantify the extent of skin disease in a patient with scleroderma. So she had very limited involvement just of her fingers, and she had positive nail fold capillary changes. In terms of her laboratory tests, her CBC and comprehensive metabolic panel were all normal. She did not have elevated inflammatory markers. Her CK and aldolase were also within normal limits, but she did have an elevated NT-proBNP. And then in terms of her serological studies, she was high titer ANA positive with a nucleolar pattern. And she also had an anti-centromere antibody that was also positive. The nucleolar pattern we often see in patients with scleroderma with pulmonary hypertension. Similarly, we see centromere antibody positivity in patients who develop PH with scleroderma. So we looked back at the historical studies that she had done when she was seen by her outside providers. And she did have pulmonary function testing back in 2013, which demonstrated mild restriction. So her FVC at that time was 75% predicted. Her DLCO was 66% predicted. And these were the details of her right heart cath at that time. I mentioned her mean PAP was 56. She had a low wedge pressure. And in addition, she underwent a TTE, which also estimated her RVSP to be 91, so significantly elevated. She had a small pericardial effusion as well as a severely enlarged right ventricle size. And this was the report that we got of her CT angio. And it was notable for an enlarged pulmonary artery. And the report indicated that there was no evidence of any interstitial lung disease. So we diagnosed this patient with limited systemic sclerosis, and we repeated her pulmonary function test. And you can see that her FVC was essentially unchanged, but her DLCO had declined now to 15.35 or 55% predicted. We also did a workup for her reflux disease. And so on an upper endoscopy, her lower esophageal sphincter was wide open. She also had no esophageal peristalsis, which again is consistent with scleroderma GI involvement. In addition, she had manometry, which demonstrated absent contractility. And finally, we did a lactulose breath test, which was positive, indicating the presence of small intestinal bacterial overgrowth. Again, another sign of systemic sclerosis. So in all of our patients, and I want to hear what the other panelists think here today, but in all of our patients, we like to get the actual CD with the images to review during our MDD at my center at UCLA versus just relying on an outside report. So this was her CTA from 2013, and I'm curious, Dr. Hobbs, what are your thoughts about this CT? And I have some arrows pointing to.
Yeah. So my name is Stephen Hobbs. I'm the radiologist of the day, and I would 100% endorse what you were saying about actually looking at the images yourself and getting the images, the actual full quality DICOM images over from other institutions, which I think probably most everybody here realizes is quite the chore sometimes to get things over. But here, you do see a very subtle abnormality. The red arrows kind of point to it and draw it to your attention. This is a PE protocol, and seeing this type of abnormality on a CT-PE protocol is pretty common. And it can be very challenging sometimes to figure out, is this real or is it not? And a lot of that comes down to technique and index of suspicion. So, you know, if this was reported by someone, does it surprise me that they did not see any evidence of ILD and they called it negative? No, honestly, it doesn't surprise me that that was the report at all. But in the right context, you would have an index of suspicion that might warrant some further evaluation.
Absolutely. No, thank you for that insight. And I think I've found as a rheumatologist can be really helpful when I'm ordering these CTs to specify what I'm looking for, because I think sometimes well, there is evidence, I think, in the radiology literature that if you have some kind of pretext for what you're looking for, it probably improves your diagnostic accuracy. So our radiologist noted subtle posterior subpleural reticulation, textured ground glass opacity in the bilateral lobar lobes, consistent with probably mild pulmonary fibrosis. And this is in the context of this patient, right, who has some mild restriction on her PFTs, has a diagnosis of scleroderma. It looks like she had early ILD back in 2013. So we repeated her CT of the chest, and even though her pulmonary function testing, or FVC, had stayed about the same, we decided to see if there had been any interval progression radiographically of her interstitial lung disease. And here are the images from her 2016 CT of the chest. Dr. Hobbs, what do you think about the CT now for this patient?
So I think it's fairly apparent that the answer is yes. There has absolutely been progression of disease. The extent of abnormality is significantly increased. There is significant lower lung abnormality now, with a combination of ground glass opacity and reticulation, this kind of interlocking linear lines in some of these areas, and is producing architectural distortion. The normal secondary pulmonary lobules aren't forming nice little hexagonal shapes. They're being tethered and pulled apart. That's that architectural distortion telling us that there is fibrosis here. In the lung periphery, you can see there are dilated and tethered open airways as well. So there is traction bronchiectasis and a little bit of bronchiolectasis as well. But I would not say that there's honeycomb cyst formation off of this. And so if I'm looking at this, there's a lot of ground glass and a lot of reticulation and fibrosis in those areas, certainly much progressed from what it was previously. But this to me would not be a classic UIP pattern. So I'd be thinking about alternative things in this particular case.
Right, absolutely. And that's sort of what we felt too in this case, that there was definitely now more moderate pulmonary fibrosis, evidence of disease progression, and more consistent with an NSIP pattern, which is, again, very typical for patients with connective tissue disease like scleroderma. And just again to note that this was a case where the patient basically had an unchanged FVC percent predicted, but progression radiographically. And we sometimes see that these two don't often go in parallel. The other thing
Actually,
that
I'd love to jump in on that.
Yeah, please do.
You know, I think it's an interesting phenomenon when you have, let's say, stable spirometry physiology where maybe symptoms have progressed and radiology has progressed, and it's, you know, it's not kind of our usual thought process that we would that we would see that disunion of things. So I think the case nicely illustrates how important it is that as maybe the clinician side of things, as the pulmonologist, that, you know, if I'm seeing this patient and they're telling me how they're more short of breath and they're on more oxygen than they were before, perhaps, or someone's gotten a radiology exam for some reason and we see the progression, or perhaps if it wasn't, if there wasn't a new CT scan yet, that this might be a patient in who might get a new CT scan, even though that's not my usual approach to things, to see if, to try and break the tie there and see if there really is progression of disease. I don't know if, Teja, do you have anything additional to say about that phenomenon?
No, I agree. I think that's, it's not usual that we see this, but especially when they're in early stages of the disease, we've seen that the FVC doesn't necessarily always correlate. And you know, getting HRCTs, I know there's no definitive guidelines on how often we should get CT scans on patients with scleroderma or rheumatoid arthritis related ILDs, but definitely something to take into consideration, especially when, you know, there were early ILA or changes that were seen in that initial CT scan. It'd be prudent to monitor closely.
Yeah. The other thing too to keep in mind is that, you know, and I'm sure as pulmonologists, you experience this all the time, where patients, if they go to different pulmonary function labs, sometimes there's not always consistency between labs. So this patient, her first PFT was done outside of UCLA, and sometimes it's hard to compare if protocols are different.
Yeah, actually on that comment, this is why we as pulmonologists usually look at the absolute numbers of the forced vital capacity rather than the percent predicted, because there you might have different standards used to provide the expected, or the therapist might put in a different height or put the wrong ethnic group in, and that can change all those things. So I always follow that forced vital capacity liter number instead of the percent.
Yeah, I think there's a great question from the audience too here, which says, had she lost weight from 2013 to 2016? That's a very important factor that we sometimes tend to overlook, which brings me back to the point that Dan made. Look at the actual liters also, not just the percent FVC. The change might not reflect as much as it does with the liters, you know. The other point of that question was, I wonder if her total lung capacity dropped from the initial 87%. I don't know if we have that data, but in our practice though, we after the initial diagnosis of a restrictive pattern based on the pulmonary function test, we don't necessarily always monitor TLC, but rather focus on FVC and DLCO. Dan, is that something similar that you'll do there as well?
That's our mainstay. In fact, forced vital has FVC most of the time, just because that's more easily obtainable in the midst of every clinic visit, whereas the DLCO and certainly the volumes just take more time, and it's not as practical to be doing it all the time.
Yeah, so she didn't have a TLC on the outside PFT, but we of course got one at UCLA. And I think there's a lot of research too showing that at least in scleroderma, the FVC doesn't correlate very well with the radiographic extent of fibrosis. The DLC probably more closely approximates it. So I think the other impetus for doing the CT was that she did have a significant decline in her DLCO. So that could have been progression of pH, but her pH was under pretty good control at that point. So there were a couple other things that I thought it would be good to get a radiology input on, and that is some other things that you can look for on CT. Say you didn't know this patient had an underlying CTD and they had NSIP, other features that might suggest connective tissue disease.
Yeah, so absolutely. Here pointed out the patulous esophagus, certainly seen in connective tissue disease fairly frequently, especially, scleroderma. And then also you've noted the enlarged pulmonary artery size. In this particular case, the pulmonary artery, the main pulmonary artery is actually larger than the aorta next to it, which always is a good internal measurement. So you don't even have to measure it. I know that it's enlarged just by looking at it. In most of the radiology literature, the upper limits of normal for the main pulmonary artery is generally considered to be about 3 centimeters. But I can tell you, if I were to call possible pulmonary hypertension and everybody who had a 31 millimeter main pulmonary artery, I'd be way over calling possible pulmonary arterial hypertension. So the larger it gets, certainly the index of suspicion goes up. So by the time you get to 34, 35, 36, my index of suspicion is pretty high. Or like in this case, if the main pulmonary artery is actually larger than the aorta next to it, that my index of suspicion is very high too. But I don't call possible pulmonary hypertension in everybody who has a 31 or 32 millimeter main pulmonary artery at the same time.
Oh, that's very helpful. Thank you. I also wanted to just kind of graphically demonstrate her course of lung function. So I saw her again back in 2016 around here. And at that time, she decided she didn't want to start therapy. She wanted to wait and kind of see how she felt because she was feeling better at that time. But over the course of the next year, she actually had a decline, not only in the DLCO, but also in the FVC. So we decided to initiate mycophenolate, which is considered the first line agent for most patients with SSc-ILD. And she actually, in the year following starting mycophenolate, had a significant improvement in both her FVC and DLCO. And this is something that we often see in patients where we can treat them early on for their ILD, that they experience this improvement. And this is also what we saw in the scleroderma lung study too, which was a randomized controlled trial comparing mycophenolate with cyclophosphamide for the treatment of SSc-ILD. But then unfortunately, the patient moved out of state, and because she was feeling better, she decided to just go off of her mycophenolate. And I actually ended up running into her at a Scleroderma Foundation meeting 2 years later. And when she was talking to me at the meeting, I noticed that she was short of breath just speaking with me. So I convinced her to come back to UCLA. And when she came back, she had PFTs, which again demonstrated decline in her FVC and DLCO. And then we repeated her CT. So again, looking back at this course of the FVC DLCO, you can see that she had this improvement when she started mycophenolate. When it was stopped, there was a further decline. And if we look at her CT, anyone want to chime in on, it's pretty obvious here, but what would you say?
Yeah, so pretty unfortunately clear-cut progression again of disease. The amount of lower lung traction bronchiectasis and architectural distortion has significantly increased. I mean, the bronchiectasis alone is much more pronounced. And in the right lower lobe, there's also a lot of bronchovascular consolidation kind of radiating along the bronchovascular bundles where there's this kind of thick, almost soft tissue-like density kind of around that. And when you start to see that kind of bronchovascular consolidation, you would also wonder about the possibility of like an organizing pneumonia or aspiration that might be superimposed on top of the actual underlying ILD. So it's a consideration, something to think of. But again, clear-cut progression of what now looks like an absolutely classic case of fibrotic NSIP.
Yeah, and the pulmonologists have anything they want to add?
Well, I think the case overall illustrates the reality that rheumatologic disease, connective tissue disease, perhaps in the absence of respiratory symptoms, it can still be there, and it needs to be screened for. And I think it's incumbent on us to educate our colleagues in primary care and rheumatology that in caring for patients with rheumatoid arthritis or scleroderma or other things, that there should be not just review of symptoms on a periodic basis, but probably an annual PFT and occasionally a CT scan, especially if there is some indication of disease progression through looking at the respiratory, through the pulmonary function tests or the respiratory review systems.
I agree with what Dan said too. I think it's really important, especially once we know that this patient has ILD, that it's prudent to educate the patient, educate other providers about the follow-up on PFTs for these patients, plus or minus CT scans, depending on how their symptom management is. Because there's a variety of treatment options now. I mean, with starting the patient with mycophenolate, clearly she did have an improvement in her lung function at the beginning. And then when she stopped, there's clear decline in her lung function. And I think educating the patient about the medication, what the benefits are, would be key. And then the next question would be, when do we add antifibrotic therapy into her regimen? Those are key considerations. I know you have more slides coming up about that, and we can discuss it later.
Yeah, no, I think I appreciate that input. And I think, as a rheumatologist, we're not often trained to screen patients for lung diseases, or at least I wasn't trained until I did pulmonary training in addition. But I would say sometimes it's challenging because if a patient has significant arthritis or myositis, they're usually not exercising very much. And so to ask them, do you get short of breath? The answer may be no, but it may be no because they're just not moving around very much. So I think screening all patients is actually quite important. So we decided to restart mycophenolate in this patient since she did have some improvement early on, but given that there'd been such considerable progression of disease and it was looking like this patient might be on her way to needing a lung transplant, we decided to add an intentative to prevent the further loss of lung function. And then we referred her for a right heart cath just to make sure that her pH was under control too, because I think when a patient has both ILD and pH, sometimes it's hard to know whether which one is driving the increase in symptoms and the decline in the DLCO. But I think the other thing that this case illustrates is how unique every patient with connective tissue diseases really are, especially scleroderma. Pulmonary hypertension is usually something that develops later in the course of scleroderma. So in this case, the patient's presenting symptom of her scleroderma was actually pulmonary hypertension. And it developed prior to the development or detection of her ILD. In addition, we've kind of already spoke about this, but again, we'll just reinforce the importance of looking at the actual images. And I think a CTA, and I'd be curious, Dr. Hobbs, what you think, but really we want to be getting high resolution chest CTs on these patients without contrast. And I don't know if you want to comment on the reasons for this.
Yeah,
for early ILD.
Yeah, absolutely. So I'll mention a couple of things about technique is kind of what you're getting at here and how we actually perform the scans. And it is important to have a good technique when you're trying to evaluate for what can sometimes be very subtle changes, even in established cases, right? Is it progressed or is it not progressed? And if there's been very mild progression, that's potentially good information. But if you don't have good technique, you just make your life harder trying to figure out whether or not it's true or not. With CTAs for pulmonary embolism specifically, a lot of people don't realize that when you take a deep breath in, it will actually impair the flow of contrast into the pulmonary arteries because you increase the intrathoracic pressure and you'll actually interrupt the contrast filling the pulmonary arteries. So we specifically generally don't tell patients to take a full breath, right? So we just can instruct them to stop breathing rather than to take a full breath and actually like you would for an HRCT. So there can be a lot of variability with a degree of inspiration on a CT-PE protocol that can increase or decrease atelectasis, which can confuse the picture for ILD fairly substantially. Now, that being said, sometimes a CT-PE protocol or CTA can answer your question just fine, right? And you don't necessarily have to repeat it just because it wasn't an HRCT. But at the same time, that's not the ideal technique for evaluating, ILD cases. And that high resolution chest CT, especially if there's very mild disease, to include expiratory imaging that you might not find small airways disease if you don't do expiratory imaging, and then the prone images really as well for that very subtle subpleural abnormality to make sure, is it true or not?
Great. No, that's helpful. And I think we had a nice question from the audience about why scleroderma does the FVC not always correlate with the extent of radiographic ILD. And there's been research into this area, and some of it has to do with the fact that in scleroderma, you can have some extrapulmonary features of the disease that can affect the FVC measurement. So for example, in a patient who has diffuse skin disease that involves their chest, this can actually create a restrictive pattern. In addition, respiratory muscle atrophy, or even patients who have overlap myositis that affects their respiratory muscles. So I think this is why we see this disconnect that you may not see in a disease like IPF, where you're just looking, at lung disease as the cause of FVC decline. Really great question. So the other thing that I think is important about this case is that we know in scleroderma there are some risk factors for progression of disease, and these risk factors include male sex, African American race, the presence of diffuse skin disease, the SCL70 antibody, and then having a greater extent of ILD at baseline and lower FVC at baseline. This patient had none of those factors, right? She was relatively young, Caucasian, centromere antibody positive, and limited disease, but she did experience significant progression when she stopped therapy. So I think that we really have to look at sort of the whole patient and not stop screening them vigilantly, even if they don't have these risk factors for progression. And then finally, again, the interval HRCT assessment was really key in this patient, because even from 2013 to 2016, her FVC was relatively the same, and she still had radiographic progression. So I wanted to hear, what other questions you have and any other thoughts from the group today. Again, thank you for tuning into this presentation.
Dr. Volkman, thanks so much for that case. That's super interesting. I had a question. I mean, that was a really remarkable recovery when you started the mycophenolate in the first go round. Do you think that might be an indicator that her disease at that time was more inflammatory rather than fibrotic, or can you not really make that depiction just based on the response?
No, I think it's a great question. And I think early in the course of scleroderma lung disease, we think that there's more of an inflammatory phenotype. Certainly, we tend to see more ground glass opacity on the CT scan. And if you consider that to be a sign of inflammation, then we usually see more ground glass predominance early on, later, more reticulation. As a pathologist, I'm just curious, I'm not sure how many pathology cases of SSc-ILD you see anymore. We don't do too much at my center, but would you say pathologically that's what you see on your examination?
Yeah, I mean, I don't think that the scleroderma-related cases are as inflammatory as, like, for example, a rheumatoid arthritis-related case would be. I mean, those are very well pathognomically known for being very inflammatory. But yeah, I think that exactly as you described it is the way I understand it as well, is that initially it may be more inflammatory, but then as the pattern progresses, usually patients who have scleroderma are more of an NSIP pattern or have more of an airway-centered component, which even on that early imaging, it seemed like there was a little more of an airway-centric aspect to it. So it could have been a bit mixed. So it's fascinating, but as you say, we don't tend to get a lot of biopsies early on when patients are asymptomatic, especially when they have a known diagnosis. So kind of have a bit of gap in our knowledge there about histologically what those cases look like.
Right. And I think the other important point that all of you kind of brought up was that we do have now more therapies for patients with scleroderma ILD. So I think it'll be up to us and the research we do to be able to figure out, are there certain features on CT or pathology, if it's available, that we can use to help select treatments for these patients, more applying a precision medicine model to how we care for them. Yeah.
So as a mock MDD or live MDD that we're doing, we should make sure that we come to a conclusion about what we think the diagnosis is. And I'm sure that this seems like a slam dunk, and it probably is, but let's just make sure we all agree. So there's a patient with established scleroderma by, officially said so by a rheumatologist, and an ILD pattern that's consistent with that diagnosis, and in fact doesn't look like a UIP pattern. So we think this is scleroderma ILD. Okay.
Yep.
Had to do that officially for the for the record keeping here. We do have another question. Yes.
No, I think this case beautifully puts together a diagnosis of scleroderma ILD. I mean, this is a patient that we would not recommend doing a biopsy on unless there were like several other factors which confounded our diagnosis, in a patient who has established scleroderma and now has features of ILD. I think our diagnosis typically leads towards a scleroderma-related ILD.
Yeah, and I'm sure Dr. Hariri is similar to my pathologist in being disappointed that we're not going to get biopsies in all the patients, but in fact, that's
we want to see it all. We want to see everything.
We have 40 seconds. We can talk about another question that came up that I think is easily answered by Dr. Hobbs. So is bronchiectasis usually present with IPF, or is that an indicator that the patient may need to be checked for a different ILD?
So a little bit of both. So there are many causes of bronchiectasis. Not all of them are what you would consider to be stereotypical interstitial lung disease. Some of them can be airway-centered abnormalities. Chronic recurrent aspiration can cause bronchiectasis that is lower lung predominant. Immunodeficiencies can cause bronchiectasis as well. But if you don't have a known reason for it, then yes, you should, be evaluating those patients to figure out what the cause of the bronchiectasis or the ILD that's causing it is. And a lot of times on imaging, we can distinguish or at least point in the right direction whether or not we think it's really an airway-centered abnormality or something abnormal in the interstitium and the alveoli that's actually tethering the airways apart.
Yeah, but IPF certainly can have bronchiectasis.
Oh yeah, absolutely.
Okay. Good. Great discussion, everybody. And thank you, Dr. Volkman, for putting that all together.
Thank you.
Next, we'll move on to our next presentation.
Yeah. So I'm going to present the next case. And again, my name is Stephen Hobbs from the University of Kentucky. So let's just get into it. So 65-year-old female referred with dyspnea, cough, and wheezing. Had not had any cardiopulmonary symptoms that she was reporting until she developed symptoms fairly rapidly over about 4 months. Had this acute decline, started to actually turn color with exertion, and had some significant weight loss in association with this. Doing kind of a more complete evaluation, past medical history, relatively, nothing particularly of interest at first glance, childhood seizures, hypothyroidism, some reflux and carpal tunnel. Medications weren't particularly unusual either, thyroid placement, PPI, no known allergies or anything like that. Social history, important, no smoking, occasional alcohol use, but no history of any recreational drugs, marijuana, or any other inhalational or IV related exposures, and has, probably a relatively typical family history for a lot of people too. A father with some heart disease of some sort, a mom with a stroke and a history of DVTs, and a sister with diverticulosis and, had her gallbladder taken out probably at some point in time. When we get into occupational environmental history, she does work in pharmaceutical manufacturing, so that's at least a little bit of something to consider, some potential occupational exposures in that setting, but nothing that would suggest an exposure to asbestos, no, farming, mining, hot tubs, no history of mold or water damage exposure in the house, or anything like that. Birds or something, we love to ask about in ILD, certainly. So had a remote history of a pet bird as a child, and uses down pillows, and that was pretty much it. Physical examination, again, not really showing up much except for the lungs, where there were some crackles noted, but no wheezing. Nothing to suggest an upper airway abnormality, and nothing with the skin or connective tissue system that was noted. Laboratory, pretty much negative. ANA, ANCA, RF negative, sedimentation rate 26, but pulmonary physiology, the FVC of 41%, and couldn't even do DLCO because of coughing. Gas exchange as well, desaturation after 6 minutes as well. So some fairly significant abnormality there. So then that gets us into my favorite topic. So the actual pictures to go along with us. So those findings, the crackles and the decreased FVC, et cetera, prompted the HRCT. And here we're starting with axial images through the chest. So this one's up through the level of the mid-trachea, so relatively through the upper lungs. And we do already see from some fairly significant abnormality. So there's a combination of reticulation and actual architectural distortion, especially as you notice here in the right upper lobe, where you can actually see some of these distal airways being tethered open a little bit with some bronchiectasis and bronchiolectasis. But then you'll also notice there's some areas of what we'll call mosaic attenuation, where there are areas of hyper lucency here in the lungs that seem to correspond with areas of the secondary pulmonary lobule in these kind of geographic areas of low attenuation compared to more normal looking lung, and then some lung that has a little bit more ground glass abnormality. So there's some fibrosis here, and there is some mosaic attenuation here as well. As we go a little bit more inferior, we see again a lot of reticulation. We see some more clear-cut bronchiectasis. You can see how tethered this airway is. Reticulation and ground glass abnormality around it, kind of tethering these airways open, and then some more pronounced mosaic attenuation on this inspiratory scan as well. And then down towards the lower lungs as well, again, so an overall fairly diffuse abnormality overall with some mosaic attenuation and fibrosis and bronchiectasis, reticulation, and architectural distortion. And again, showing you a similar sort of thing as we go even more inferiorly. So on the coronal images here, I've highlighted the fact that yes, there is lower lung involvement, but I showed you some mid and upper lung involvement as well. And again, highlighting this mosaic attenuation, these geographic and lobular areas of hyperlucency here. So-called mosaic attenuation. And then we come to an inspiratory CT on the left, and then an expiratory CT here on the right. So these are done through the same general imaging plane, and we can see that on expiration, these areas of hyperlucency persist. The areas of non-air trapping get grayer, and the areas of hyperlucency that we call mosaic attenuation on inspiratory scan are confirmed as areas of air trapping on expiratory scan. And we really do need a lot of times that expiratory scan. This case is fairly obvious, but the expiratory images to really confirm that that mosaic attenuation is due to air trapping in this case, rather than some other causes of mosaic attenuation like a vascular perfusion anomaly or something.
Steve, so, Dr. Hobbs, the expiratory picture there, I don't see much narrowing of the trachea, whereas I think we're supposed to. Can you speak to that in this case and in general?
Yeah, so that is a good way to gauge in many cases if the expiratory effort was good or not, but it isn't always seen. But it can be a good clue that expiratory effort wasn't good. So in this particular case, I can look at the overall lung volumes and see the normal lung and see that it's grayer to tell you that, yes, a good expiratory effort was actually made, despite the fact that the posterior wall of the trachea doesn't bow anteriorly like the classic teaching is. But if I did both of these sequences and the inspiratory looked exactly like the expiratory did, then that looking to the trachea to see if you see that bowing is a good clue to whether or not it's a good expiratory exam or not. If it doesn't, you have to wonder, okay, is this a bad effort, or does this patient really have diffuse obstruction involving everything? And that can happen in some disease processes like obliterative bronchiolitis or constrictive bronchiolitis, but it would always raise that question.
Thanks, that's great.
Yep. So in summary, for the images here, we've got a relatively diffuse fibrosis with evidence of small airways disease. And so this pattern of abnormality, imaging wise, is strongly suggestive of fibrotic hypersensitivity pneumonitis. You guys have probably all read the updated classification that has imaging guidelines for how we're classifying the imaging patterns seen with HP now. We've moved away from the subacute and acute and chronic classifications into the fibrotic and non-fibrotic. And there are typical, compatible, and indeterminate for HP patterns inside that fibrotic pattern. This, to me, would be actually classified as typical HP. So we've got a case now where me as an imager, I'm going to say that this looks like HP, and that's probably my lead diagnosis here. But clinical wise, you've got some possible exposures with, maybe they're using down, pillows potentially, maybe an occupational exposure at work in the pharmaceutical industry or something, but nothing that's really a slam dunk. The rest of her physical exam doesn't necessarily suggest a connective tissue disease. At least a little bit of lab work that's been done doesn't suggest anything. So what would kind of be next steps for the group?
So, so when I see a patient like this, when there's suspicion for ILD, I think one of the factors is definitely that there's some concerns for exposure, and the CT pattern suggesting that this might be HP. But given the demographics, I think I would like to see like a complete rheumatological panel to ensure that we're not missing any autoimmune conditions. Like you mentioned, that bronchiolitis can sometimes cause air trapping like this. And there are some rheumatological conditions like RA and Sjogren's that can present with bronchiolitis as well. So based on like what has been recommended in the guidelines, I would definitely get a complete serological panel. Dan, would that be a similar practice for you as well?
Yeah, most definitely. I'm constantly surprised, and so is my whole rheumatology division, constantly surprised at the things that come about from our evaluations of folks. And the Sjogren's antibodies are elevated unexpectedly, and then you probe them some more, and they don't have a lot of sicca, but the lip biopsy shows us something, or the ophthalmologist tells us something that helps to confirm that diagnosis, or maybe prompts us to think about a biopsy in some of those cases in order to try to clarify things further. But I definitely, I think this case highlights the importance of a robust rheumatology panel looking for all sorts of different things.
Yeah, and one thing I would add is that, it's interesting to me as a rheumatologist when I see what gets ordered when patients go to a pulmonologist in terms of the serologies. And very often it's what was done here in an ANA and a rheumatoid factor, and I think they did an ANCA. And when you think about these autoantibodies, the ANA and the rheumatoid factor are probably the most non-specific antibodies that you could order for a patient. They're present in a lot of different things, even outside of connective tissue disease. So I'm curious, which ones do you guys order in your practice, and how do you decide which ones to order? Or do you just leave it up to the rheumatologist?
Well, first of all, in some cases in which there's some other clear-cut exposure and it's a clear-cut hypersensitivity pneumonitis, not this case, but a different one, I might actually attenuate some of those serology panels. But if it's a nondescript new ILD case like the one I saw this morning, I'm gonna send off not just a rheumatoid factor and an ANA, but an anti-CCP. I'm going to get an ENA panel looking for those Sjogren's antibodies, the scleroderma antibody, the RNP antibody. I'll get a CK and an aldolase on almost everybody, maybe as a cheap way of looking into the myositis question. But I'm, at least in my practice and our group's practice, we're not going to get the whole myositis panel or biomarker panel or whatever you want to talk about there. In every case, and just knowing how expensive it is and that it's a send out and everything. So maybe if there's a different clue, like mechanics hands, even subtle mechanics hands, or if I pick up something on the myositis panel, or they're describing or showing me on exam some muscle soreness or weakness, these might be reasons for me to delve into that deeper panel of things. But and I'll get the inflammatory markers, an ESR and a CRP on everybody as well. Teja, what's your group usual practice?
It's a similar approach. I think we tend to do myositis panels a little bit more, especially based on the demographics. I mean, if it's a younger patient, particularly females, I mean, the tendency to do that is much higher than we would otherwise. I mean, if you look at the guidelines, really, I think, although just a limited panel was recommended for IPF diagnosis, sorry about that background. Most of the panel did say that they would consider doing a more extensive panel as well.
And I'm curious if you guys do you guys do bronchs to get BALs if you're thinking about HP, or do you order HP panels? Like, do those play into your decision making?
So I'm not going to get in a BAL or do a bronchoscopy on everybody who in order to secure the diagnosis of HP. If I've got a pretty significant exposure and we've got a radiology pattern that is indicative of that diagnosis, I'm not going to most of the time. In a different case, in fact, in this case, where there's some exposure, there's the down pillows, but and that very well may be enough of an exposure, and it is in a lot of people. I've seen that, and I've seen other furniture, and I've seen clothing down, all eventually implicated in a secure diagnosis of HP. But in a case like this, where there's some exposure, but not enough of one to hit me over the head, but there's radiology like this, I think a BAL looking for lymphocytosis is probably a very good step in order, as a way of, and not to be jumping into a surgical lung biopsy on everybody as a next first step.
Mm-hmm. Well, that might be a good lead in to the rest of the case. So this is an older case, but the rest of the rheumatologic workup didn't really reveal any particular direction to go into as far as an underlying connective tissue disease or anything like that. And so this patient did actually go for a biopsy. So Dr. Hariri, do you want to comment on what you see here? Because this image has too many colors for the radiologist.
Sure, I'd be happy to. So even from low power here, you can see that the bottom right-hand corner, that's where the pleural tissue exists. And this is clearly not a subpleural predominant disease. In fact, when you look, you can start to get an essence that this is a little bit more airway centered, meaning that the disease is really focused around the airway and interested in the airway. There's mixed, what we very crudely refer to as pink and blue, which basically means that there's both inflammation and fibrosis present. So a fibroinflammatory condition plus airway-centric disease leads us to start to look for etiologic clues like granulomas, other bigger lymphoid aggregates, especially if they contain germinal centers, to help us start narrow our differential to see if we can pick up an etiology like hypersensitivity, aspiration, or connective tissue disease. And then in this picture here, we have an airway that's, respiratory epithelial line. There's a thin, smooth muscle layer underneath. There's no cartilage. So we're at the level of a bronchiole. You can see already that there's quite a bit of blue chronic inflammation present. Even at this low of power, I can start to see that there are these hazy aggregates of more pink qualitied cells, which make me think that there's probably some loose histiocytic aggregates hiding in there. So I'd like to look at higher power to see if I can confirm that, make sure that's what I'm really seeing. And lo and behold, there they are. So this is an aggregate here of histiocytes that are having what I lovingly in our MDD refer to as a little bit of a party. There's some giant cells which have multinucleation there at the top. And the picture here is quite classic in that from low power, I couldn't identify with high confidence that yes, that's absolutely a aggregate of histiocytes the way that you can in, for example, like a sarcoid case where I don't even need to look at high power. I look from low power and say, oh yeah, those are definitely granulomas, so very likely to be sarcoid or maybe infection. Here, they're not as obvious when you look from low power, but as soon as you go to higher power, you see these pink, ill-defined cells that are really the hallmark of an inhalational exposure, which here, given the picture radiologically, my top differential would be hypersensitivity, but I would also consider things like aspiration-related disease. And then also given this patient's history, I would want to make sure that I polarized these to look for any birefringent material like pill fillers that could be inhaled because of their exposure, but that would be birefringent, whereas you wouldn't expect there to be birefringent materials in HP or aspiration, unless they're aspirating pill particles, which then takes you down a whole other rabbit hole.
That would.
Same here. This is a little looser picture of a histiocytic aggregate. You can see a couple of giant cells more towards the left-hand side of the image, but again, in keeping with what we've seen in the other photos.
Okay.
A little bit of organizing pneumonia here too. You can see this blue myxoid picture here, indicating that there's a bit of a subacute component as well, a little bit of younger injury.
Okay. So, my follow-up question for that, you've got imaging that would be classified as typical for, HP, fibrotic HP based off of the imaging pattern that we see. Maybe not a great, exposure history. You got some potential stuff, but not really much else clinically to point you in the right direction. And you got pathology that is certainly consistent with that as well. Is that enough to cinch the diagnosis for us here, or is there something additional we do? What would be next steps? Is this the presumptive diagnosis or what?
Yeah, I think based on what we're looking at the CT scan, yes, the exposure is not the usual exposures that we expect to see with HP, but has been in discussion more recently quite a bit. And with that pathology, I think a diagnosis of hypersensitivity pneumonitis is certainly something we can pinpoint on at this point. Dan, do you agree?
Yeah, I agree that this, I'm happy with the diagnosis of HP here and with the probable exposure being the down pillows, although I think we have to recognize that a large percentage of patients with documented HP do not have an identifiable exposure. And in this patient, it might not be the down pillows. Even if we want to hang our head on that, I wouldn't do so with confidence. We must continue to be vigilant with our patient and follow up visits, asking about other possible exposures, perhaps providing them with lists and checklists and things of potential exposures that you might get from the Chest Foundation or other places, trying to look for things that they're not thinking of as we ask them the question, or questions that we're not asking that we ought to be asking, looking for what that exposure is, because we all know too well that the primary and most important treatment intervention in these patients is to remove them from the exposure, remove the exposure from them. So, sometimes that's going to be finding the mold problem in the house that was unrecognized before, or realizing that some place that they go very often has a bird or mold problem that is the etiology, and recognizing that and getting away from it. yes, so I think it's HP and may or may not be the down, I guess is my bottom line, but I'd make sure they get rid of the down and any other shapes or forms in the home. I not long ago was sitting on my sofa in my own house and got poked by something coming through the cushion. And I said, what is this? And I pulled a feather out and I said, oh my goodness, I didn't know that I owned a down sofa. So, how many of our patients might have the same type of experience and not realize that they have other forms of organic exposure that they're around?
Yeah, it's really important on how you question the patient about these exposures. You're just asking a generic, like, do you know of any particular exposures may not be sufficient. Actually, one of the audience questions, and it's a great question at your center, do you use a formal exposure questionnaire for ILD? We don't actually have like a very formal or particular questionnaire that we use. I mean, if you look at the some of the websites, you could get a list, and it's a very extensive list, but we do have as a part of our ILD questionnaire at least some of the basic exposures that that include exposures to mold or water damage, birds. Surprisingly see them a lot more than we expect. Exposure to down comforters and pillows and such, and definitely other occupational exposures, but does not really include the whole extensive questionnaire that you'd expect to see. And as Dr. Dilling mentioned, I mean, in a majority of these HP patients, almost about half the HP patients, we may not even identify an actual exposure, and so it'd be important to ask the patient-specific questions as you go.
There was an audience question asking if there had been, in this case, a BAL and lymphocytosis present, and no, there wasn't. And I think it might have mitigated the need for a surgical lung biopsy. I'm sorry, Dr. Harari, that we might have missed an opportunity for pathology examination here, but yeah, I think with that story and that radiology with lymphocytosis and a BAL, I think I might have stopped in this patient without a biopsy. I don't know if others agree here.
Yeah, I think it would be similar at our center too. We probably would not, if there was lymphocytosis present, definitely would not have biopsied this patient. But also taking into consideration that this patient has a fairly fibrotic CT scan. And I think if you look at the guidelines, I mean, yes, BAL and lymphocytosis and looking for lymphocytosis is recommended, but the caveat being that in cellular HP, I think this would be more meaningful than it would be with fibrotic phenotype. You may not see as much lymphocytosis in a patient with fibrotic HP.
But I think the conversation here does highlight how valuable a thoracic radiologist is, and how valuable the multidisciplinary discussion is with that radiologist to try and see these subtleties on the imaging that can make major decision, can have major implications on decision making, biopsy versus a bronchoscopy, for example, here.
Yes, and I think it's really important to highlight these factors, right? I mean, with surgical lung biopsies, doing it does come with a risk that for a diagnostic testing, even that 1 to 2% risk of severe respiratory failure or death is fairly high, and really highlights the importance of discussing all this before we proceed to a surgical lung biopsy. And there's one more question from the audience. I think Dr. Hobbs might be more for you. Anything from the CT or PATH that suggests GL-ILD? Would it be worth checking immunoglobulin levels in these patients?
So I don't generally see this amount of fibrosis like we saw in this case with most cases of glial that I've seen before. I've seen a lot more HP than I have seen of glial. It's a relatively rare diagnosis, at least in our practice. And for us, it tends to manifest more as lower lung predominant ground glass opacities and nodules that I suppose you could, potentially wonder about with, a non-fibrotic HP pattern rather than the fibrosis that you've seen here. Obviously, if there's other evidence of immunodeficiency, CVID, which, we might see splenomegaly or something like that, and then that would be a different case too. Or, I think there's an association with glial and, Kabuki syndrome and, that type of thing too. But this CT in particular doesn't scream glial to me when I look at it.
Yeah, similar for the path. If it were only sort of the non-fibrotic components, you could entertain a possibility of CVID can present very similarly pathologically as HP does. But with that level of fibrosis, it doesn't really fit, especially without a good clinical picture to go with it. And then GLILD, from a pathology perspective, tends to have more of an interstitial component in association with an airway-centered component. It's the CVID specifically that tends to look a little more HP-like on path.
All right, and we have another question. This is directed at the pulmonologist. So do we have a standardized list of questions that we ask patients that we follow? And I suppose it might, I guess what I would say is it depends somewhat on what kind of patient we're talking about. So, if it's a patient who's got IPF and it's clearly been diagnosed through our MDD process, then I might periodically revisit questions around autoimmunity, but most of my questions are going to be about disease progression and tolerance of antifibrotic medications. In a patient with HP, especially an HP with a non-identified antigen, I think I try to revisit questions around antigen exposure and maybe even find new checklists to give them or something looking for it. Anyone else?
Yeah, I think a similar pattern really depends on what patient we're following. In an HP patient, it's really important to keep asking again and again about exposures. Another aspect that we found helpful, and so for HP patients, particularly talking about this case, is asking them to get a professional an evaluation of their house done and asking questions around these exposures. That might be helpful, but mostly depends on patient to patient on what kind of questions we ask them.
Awesome. Well, another great discussion. Thank you, everybody, for all the great ideas and the audience for the great questions. Please keep those coming in case 3.
Great. So I'm going to be presenting case 3. Let me just get my wonderful. So this is a 64-year-old gentleman who was undergoing screening CTs for a smoking history, and a lung nodule was identified on that CT. There was also some basilar predominant reticulations identified at the same time. And based on the presence of the lung nodule, concern for malignancy, the patient was scheduled to undergo a lung nodule resection. When they were questioned in their pre-op visit, the gentleman indicated that he did have a little bit of shortness of breath, but on exertion only, and he had a pretty extensive cardiovascular history, and so he had really attributed that shortness of breath to his history of coronary artery disease. His smoking history was pretty extensive, 50 to 6 year PEC year history, but he quit quite a while ago, 20 years ago now. And so in his past medical history, as we mentioned, he had coronary artery disease, he had had myocardial infarction, a CABG also done, in-stent restenosis after having stenting done as well. He also had peripheral vascular disease as well that was fairly significant. And in keeping with his smoking history, he also had COPD. His medications were, kind of run of the mill, so to speak, some albuterol, aspirin, medications for his coronary artery disease and hypertension, nothing really of major note with relationship to his interstitial lung disease. So his social history, we mentioned, apparently I can't even keep consistent within my own notes. He had a 60-pack year history, apparently. No really significant alcohol use, no drug use. He did have 2 pet dogs, no birds. Minor asbestos exposure from a boiler he had at home that he had helped fix himself. That was remote and, unclear of what significance that would be. No family history of lung disease, no family history of connective tissue disease, some coronary artery disease within his family, and then also some history of lung cancer. His review of systems also was very consistent with his past medical history. He did have some dyspnea, some claudication on exertion, but that was initially thought to all be related to his coronary artery disease. So on physical exam, he was sitting quite nicely at 98%. His lungs actually sounded clear bilaterally. He had an ejection murmur, but otherwise his heart had a regular rate and rhythm. No rash, normal joint exam, nothing that was really indicative of a connective tissue disease, at least from a physical exam perspective. His laboratory data was really very unrevealing. Had CBC chemistries, RBC, no immunoprofiling on file as of yet. His pulmonary function test showed an FVC of 70% and a DLCO of 80%. And then I apologize ahead of time to Dr. Hobbs, leave it to the pathologist to pull radiology images and do a completely comprehensive job, but he's so good that it doesn't matter. He'll still get it.
No, happy to take a look. So here, there's a pretty subtle abnormality, right? So there is a peripheral abnormality that off of this, there is some reticulation, and you would probably call it ground glass, although I would wonder if it looks more ground glass because of how thick the section is versus a thin section HRCTs. But there is some architectural distortion and fibrosis to go along with this, but certainly nothing that I would say is a honeycomb cyst or something like that. So we do have a peripheral or subpleural lung abnormality that, in the absence of an underlying suspicious of ILD, I would specifically bring up, as an ILA or an interstitial lung abnormality, and bring up that possibility, which is kind of its own little rabbit hole. But that would be what I would suggest off of this.
Great, and I have one more slice for you.
Yeah, so as we go more inferiorly, it's actually a little bit more convincing. So again, peripherally in the subpleural lungs, more down here in the lower lungs, there's a reticular abnormality with architectural distortion, but no honeycomb cyst formation. So this does look, and it's a decent enough extent that this isn't just some minor little bit of, healed pneumonia or scar or something like that. This is an interstitial lung abnormality. It's peripheral and lower lung predominant, and it is fibrotic. So when I'm thinking about interstitial lung abnormalities, because the history here is not really suspicious of this, is like lung nodule, evaluation and everything. It gets classified into 3 different imaging patterns. Interstitial lung abnormality that's not peripheral or subpleural predominant, non-fibrotic abnormality that is peripheral and subpleural predominant, and then subpleural predominant but fibrotic abnormality. And so we're in that last category, which kind of carries some of its own prognostic issues and everything. So I'll leave it at that for the moment. We can discuss that a little bit more.
Great, thank you so much, Dr. Hobbs. Okay, so the patient underwent a right upper lobe resection of the lung nodule. It turned out to be an invasive squamous cell carcinoma that was non-keratinizing, about 1.5 centimeters in diameter. There's no lymph node involvement, so the patient was staged as a PT1B-N0, which is a pretty early stage, which is great. However, given that there was radiologic evidence of this reticular lower lobe predominant abnormality, even though this was an upper lobe resection, there was care by the pathologist to put through a lot of the parenchyma in order to look at that interstitial change that was present there. And I will take this moment as a shout out to my field, that if you have a patient who's undergoing a lung nodule resection and they have an interstitial lung disease that's symptomatic or asymptomatic, it's always helpful to give us a heads up so that we make sure we put through really extensive sampling of that parenchyma. As was noted by Dr. Volkmann's presentation earlier, that we don't know what we don't know. So if we don't know that there's some reticular abnormality there, we may not put that through. And if we undersample, then we may not recognize there's an abnormality there, which is always a missed opportunity for us to look at that pathology in both, even in patients who have a diagnosed ILD. Sometimes it can be helpful to look at those features if you happen to have the tissue for other purposes. So what we ended up seeing here was a very subtle and very focal, but present subpleural fibrotic lung abnormality. There was lots of regions that I'm not going to show for time purposes where there was only just thickening of the subpleural lung with this fibrotic dense collagen that was replacing the normal alveolar architecture. But then in a couple of small foci, what we had is evidence of architectural simplification with multicystic honeycombing. And this honeycombing is well below sub-millimeter in diameter. So that's the reason why it would be very likely we wouldn't be able to see this type of honeycombing on radiology, is just because it's outside of the resolution limitations, even in a high resolution CT. Here's just another example again, where you can see that there's some subpleural fibrosis, there's honeycomb change, and then there's evidence of fibroblastic foci again, indicative of basically an early UIP. We looked again very carefully at this to see if there was any evidence of airway center changes, if there was any granulomatous changes, and we didn't see any evidence of that pathologically.
No party going on down there?
No parties, no histiocytes having a good time down there, just nasty fibrosis present. So patient had their lung squamous cell carcinoma treated with the resection. There was no need for chemoradiation therapy based on that stage and the lack of lymph node involvement, which was great. The patient was still undergoing cardiac rehabilitation, and his dyspnea was stable with that cardiac rehab. And so there was a lot of question here about what should be done about this ILA. And I'll tell you, I was the pathologist who actually signed this case out. And first, the conversation happened with the thoracic surgeon and the oncologist, because there was so much focus on the lung cancer and making sure that that was well taken care of, that this ILA pattern sort of took a second seat. And so with some probing, things happened at my institution. But I'm curious, like, how would you guys handle this, and what would you recommend in this particular type of situation?
When you showed me this case last week, I was struck by the fact that I saw almost the same case just a few weeks ago. On my end, it was a case of stage 1 lung cancer that had been diagnosed through surgery, wedge resection, I think 2 or 3 years ago, at a different hospital, and the patient had done well from a cancer standpoint, and had come now 2 or 3 years later to develop some respiratory symptoms and progressive radiology, to the point that we were now questioning what the ILD diagnosis was. And we were able to acquire the tissue samples from the lung biopsy from years ago and re-examine that surrounding tissue, and found a UIP pattern in just the same way that you described here. And so it was a case of IPF that was just really early 3 years ago, but not so early today. And I reflected then and again in reading your case that it was a missed opportunity to have recognized early disease and started someone on disease stabilizing therapy, antifibrotic therapy, and maybe attenuated some of the symptom progression that that patient's seeing today. So I think what I would say in your case is I mean, we still need to do our due diligence and have a rheumatology workup, and make sure we have a good HP review, because UIP can be a lot of things, and it's only idiopathic UIP that is the disease we call IPF. And so we need to do that due diligence, but assuming we have no other etiology uncovered through it all, I think this is a case of IPF, and I'd propose treatment starting as soon as possible to try and halt progression and not have it turn into my recent patient that I described.
Asia, what about you? Dr. Kulkarni, I'm sorry, we're being formal today, Dr. Kulkarni.
I think a similar approach is what I would recommend as well. Once we go through the rest of the findings, I mean, based on the patient's demographics and everything, I mean, IPF is probably the best fit diagnosis. And assuming remainder of the workup is negative, we would offer antifibrotic therapy as well. I mean, there could be a lot of argument about whether, the patient is not really, or, the patient has dyspnea. Yes, it was attributed to cardiac factors initially, but there's no way to know how much of it is also from this early IPF. His FVC is already affected. It was 70%. And so, there's really no benefit at this point of saying wait and watch approach. I think, when we've looked at the clinical trials or data from the clinical trials, the decline in FVC in patients who start off at a higher FVC or greater than 80% versus those who are less than 80%, the rate of decline or loss in FVC is similar. And so if we're able to offer this patient antifibrotic therapy at this early stage and slow down the disease progression, I think it would be a win-win situation rather than we wait until we get to Dan's patient's point, where although we could still offer antifibrotic therapy at that stage, we've already lost lung function that is not recoverable. So definitely, unless there's any hesitance from the patient standpoint, which also is another challenge. I mean, we do see that in the clinic where, the patients are not very symptomatic or they feel like the disease is not really affecting them as much, and you start talking about the potential side effect profiles of the available antifibrotic therapies, patients become a little bit hesitant to start them right off the bat. But definitely in this patient, I think we should talk to them about antifibrotic therapy, and if agreeable, start them on it.
Thanks.
I think the other thing that
I'm sorry, Dr. Volkman, please go ahead.
I was just going to say, I think the other nice thing that this case illustrates is just the importance of the multidisciplinary collaboration, and that it doesn't have to just involve who's present here, right? Radiology, rheumatology, pulmonary, pathology, but even bringing in other specialists. In this case, working with the oncologist too might be important to make sure that you're not selecting a therapy that could in some way be increasing that patient's risk of recurrence of cancer. And we experience this a lot in our CTD ILD patients who have a higher risk of developing lung cancer, where we have to make the decision, do we put them back on immune suppression? And if we do, what would we choose for that patient? There was a nice study that was done this year out of Northwestern, and it was published in JAMA, looking at patients with CTD, ILD, and lung cancer outcomes. And actually the survival was no different between patients who had a CTD, ILD, and those who did not in terms of survival from lung cancer. Some of that may be like a length time bias, so they're getting diagnosed earlier because we're already screening them with their CTs for ILD. But I think this really just nicely highlights the importance of multidisciplinary collaboration.
Yeah, and I'd say, Dr. Volkman, that's exactly, I think, the point that I was just about to make, is that collaborating together with the surgeons, there have even been cases where there's an underlying ILD and they may be doing an upper lobectomy, but they're already taking the patient through mechanical ventilation. They're under general anesthesia and, taking a small sample of the lower lobe, if it's really going to help guide that second disease that they have. You're already there. The amount of risk is not the same as taking a patient de novo to a surgical lung biopsy. Like, a lot of the risk has already been undertaken. And so getting an additional sample may be helpful. And so it's been great to have those conversations with our thoracic surgeons to say, hey, this patient's also being followed by pulmonology. Can you, talk with them and see, or have the pulmonologist reach out to see if it's worth getting additional tissue. Another thing I would add here, I know there's probably not a lot of pathologists in the audience, but even for you guys as you're reading these path reports, is It's also important, I think, for us as pathologists to make sure that we're really reflecting back on the clinical and radiologic picture, especially when we have such a limited resection like this. We know that sometimes there can be very localized abnormalities. For example, right middle lobe can sometimes show UIP-like abnormalities because it's the middle lobe, and middle lobe does weird stuff sometimes because of its anatomic orientation. And so it's prudent for us as pathologists to make sure we don't overcall these abnormalities either, that may be associated with an endobronchial mass or some other thing. And this is just a localized change, and the radiology doesn't support the fact that this is a more diffuse process. And then we make a mistake of saying, oh, we see UIP here, and it's not, because it's just localized to one lobe.
Yeah, I think, Alina, Dr. Hari, that's a great point. And another point that I do want to utilize this time to focus on is, the importance of doing at least 2 or 3 lobe biopsies. I mean, a lot of thoracic surgeons only do 1 lobe when you ask for it, unless you specify that you're looking for ILD and ask for multi-lobe. I mean, for example, in this patient, this was upper lobe and showed mild changes. Maybe if we had biopsied the lower lobe, perhaps there would have been much more involvement of the lung, and that would not change the diagnosis in this particular case, but in some other patients, it might. And we've seen that where the upper lobe may show features of TIP, but lower lobe may show features of UIP in a patient if they're still smoking, for example. But I think it'd be really helpful to specify that to the surgeon and ask for 3 lobe biopsies.
Yeah, and Tasia, that's a really great point. I'm going to stop calling everyone by doctor. I'm just going to call you guys by your first name because it feels a lot more natural. And that's what we would do in an MDD. We're all friends. We refer to each other by our first names. That's one of the questions that was just brought up is, are the surgeons amiable to biopsying other lobes during a surgical lobectomy for lung cancer? And I think it depends on the surgeon. It depends on their comfort level. And also, I think it depends on the importance of the question. I mean, if the patient already has an established diagnosis of UIP, IPF, then there's really no point in getting an additional biopsy unless there's some very specific question or some additional nodule that needs to be investigated. And that should probably just be discussed to make sure everyone's on the same page. But in a situation like this, I think, Tasia, you bring up a really good point. It could have easily been that the upper lobe only showed smoking-related changes, or maybe showed an NSIP pattern, and then we would have had a disconnect between, yes, that can be seen with the same radiologic, features that Steve described, but we would have missed the UIP. We got a little bit lucky in this situation that we happened to get the diagnosis even in the upper lobe. So it's important, I think, again, for us to make sure we have, our blinders off, and that we're thinking about the whole of the imaging and the whole of the patient, and getting as much information as possible. Because in an early stage lung cancer like this, it very well could be that the UIP is actually going to lead this patient's prognosis long-term in a way that maybe the early stage squamous cell carcinoma actually isn't, even though that seems more pressing at the time.
And to answer the question directly, is my surgeon or surgeons amenable to it? And they are. It doesn't happen very often, I have to say, but yeah, if I had an ILD patient who needed a wedge resection for a nodule, they would go ahead and do a ILD surgical lung biopsy in addition to the whatever wedge or lobectomy they needed to do. But yeah, that's communication, I think, is all it takes.
And I'll say that in our MDDs, I've seen the opposite also happen, where a patient's being sent for an ILD wedge biopsy protocol, but there's also a small nodular lesion that's of concern on the imaging. That is it nodular fibrosis? Is it something else? And there have been cases where there's been a miscommunication and just a regular standard protocol ILD wedge biopsy was done. And then it's like, again, shoot, we had an opportunity to go look at that nodule that could have been sampled at the same time to just make sure, as Dr. Volkman or Elizabeth pointed out, these patients who have underlying CTDs are at higher risk, and the patients with ILDs, idiopathic, are also at higher risk, especially those with UIP. So all in all, it's just good for everybody to chat with everybody else, make sure we're on the same page.
But these are some of the cases where if your team or your hospital has somebody who's a dedicated thoracic surgeon versus a more general cardiovascular thoracic surgeon, that who's maybe doing all the lung cancer surgeries and does your ILD biopsies and kind of is your one-stop shop for it all. That person has sort of a different comfort level, different familiarity with these things, and he or she is going to see the ILD in their cancer case and think about that, and he or she is going to see the lung nodule in your ILD case and think about that as well. So I guess it demonstrates the benefits of having that extra specialty on your team, or sending somebody to a thoracic surgeon elsewhere who has that kind of specialty.
The other thing I would just add too is that for some of the participants today, they may not be practicing at an academic center where they're participating in MDD, but I think most of us now are doing virtual MDDs because of the pandemic. And so it is possible to, work closely with a local MDD. And then even if that isn't an option, I think there's ways to create sort of your own virtual MDD by, finding other specialists in the community who you can consult with on these cases, because I think all of these cases have highlighted the importance of communicating with different specialists. It can not only improve the diagnosis of the patient, but it usually improves their outcomes. And oftentimes the patients feel better too, because they know their doctors are talking to each other.
Yeah, you can bring, in the era of Zoom or Teams MDDs, you can bring the primary care doctor in, you can bring the referring pulmonologist, you can bring the rheumatologist more easily if they're not usually able to come indeed. So bringing people together, there's a little bit of lemonade we can make out of this giant lemon. I think we might be done with the slides for this case, right? Is that right?
I think so. Let me double check. Yeah.
Okay. I just want to make sure before I took any turns in the conversation here. We do have another question. So, has the use of Envisia reduced the need for surgical lung biopsy at your centers? So Envisia, a genomic classifier, Verisite's a company that does that for us. And so for those that might not be familiar with what that means or what that question's asking, there's a technology that's pretty recently become available for us that allows us to do a bronchoscopy with standard protocol for transbronchial biopsies, and to take those transbronchial biopsies and send them away for a specialized kind of analysis looking at the RNA sequence, or not sequence, the RNA patterns that are seen in the transcription of transcription patterns that are seen in the tissue, and allowing that to correlate with what we might otherwise see in a surgical lung biopsy for a UIP versus a non-UIP pattern. And it's very dichotomous that way. It's UIP versus non-UIP that you'll get in that test result. You don't get the beautiful descriptive information that you'll get from the pathologist in a surgical lung biopsy. You get UIP or not UIP. It's a fairly reliable result, and I think it is helpful in cases if you've excluded any known cause and then you get UIP and you weren't able to say that based upon the radiology, that you would be able to say UIP pattern on the Envisia test with a patient who otherwise had no identifiable cause for the fibrosis, that you can call that IPF and feel fairly confident. I'll tell you, I'm using it some, but I'm still growing in comfort with it, and I think we all probably have a ways to go before we're comfortable with it. I think the pathologists probably don't like it at all. But the things you don't get with that are information about granulomas or information about lymphocytic infiltration or other kinds of things around the pleura, or maybe you could probably say a bunch of other things about this that you miss from that. Obviously, it's a less invasive test for the patient, and that's a very good thing. And my personal bias right now is to use it in cases where I otherwise wouldn't be able to get a surgical lung biopsy and I'd be at a dead end. But if I feel like they can tolerate a bronchoscopy and transbronchial biopsy, then this is adding information. So I've gotten that far with it, but and I may get farther with it as more years go on. I wonder what others have to say.
Yeah, I think as you mentioned, Dan, we're still getting sort of comfortable with it. It really depends on a case-to-case basis. I don't think it's easy to generalize it as to how I would utilize the genomic classifier yet. Like, for example, if my differential diagnosis is a fibrotic HP versus IPF, I would have a hard time deciding what a UIP here would mean. And so I'd probably lean more towards going for a surgical lung biopsy than get a genomic classifier. But if my differential IPF is high on my differentials, but it's either early IPF or a probable or an indeterminate pattern of CT, but everything else workup wise is negative, then in that case, I feel like utilization of a classifier like this might be helpful in avoiding a surgical lung biopsy. So I think it's really a case-to-case basis on how the utilization would be. Definitely if the patient is a very high risk for surgical lung biopsy and there is a chance that UIP on the genomic classifier could help finalize on my diagnosis, I would go with it. But yeah, still working on developing a good relationship with like where that fits into our algorithm here.
All right, Lita, your turn to throw tomatoes at it.
I mean, I think you guys covered it. I'll say our institution, our pulmonologists are not using it very frequently at all. I think it has the pros and cons that you guys both highlighted quite nicely, that, yes, it's much less invasive, and yes, it can help with decision-making in some cases. But again, that doesn't seem to usually be the difficulty of UIP versus non-UIP. It's what's the pattern and what's the etiology related to the pattern. And I'm not sure that the classifier is always going to be able to answer that question. I do wonder about things like what your guys' use of cryobiopsy is at each of your centers, and how you're finding your experience with that is, and or the combination of like cryobiopsy together with the classifier. Has anybody looked at that? I don't think anybody's done published anything in the literature necessarily on that, but does anybody in practice do that?
We're also not
at our center.
Go on. Oh. Sorry, go ahead, please.
I was going to say, we do quite a lot of cryobiopsies now, and I think we've involved the interventionalist who does most of our cryobiopsies in our MDD, and I think that helps in terms of going after the location that we think would be most high yield. And we do have a study going on right now where we're looking at the Invisio and cryobiopsy, but I think the more information you have, the better. So I don't think it's going to end up being like one is the most superior thing to do. It's just like with all these cases, the more information we have, probably the better informed decisions that we can make as providers for our patients.
Yeah, we're also at our center, we don't utilize cryobiopsy a lot. We just haven't adopted it. In fact, in some of the cases where we've either done it or had pathology brought in from another hospital where it had been done before, we find a lot of times that we don't get the same level of information that we get from the surgical lung biopsy. And we've even gone on to have a surgical lung biopsy in a couple of those cases.
Yeah, I think utilization of cryobiopsy is really center dependent and dependent on the experience that the interventional pulmonary team has. In our center too, we've done very few cryobiopsies, and it's not just because of what the belief is. I think studies have shown the cryobiopsy can be equivalent in terms of like being able to diagnose, compared to surgical lung biopsy. But I think there's also caveats about like whether, cryobiopsy would be more helpful in like diagnosing features that are more airway centric than there are parenchyma. And Leda, you might be able to tell a little bit more about that, from the pathologist standpoint. But I think a lot depends really on the experience of the IP team, which has probably reduced the utilization of cryobiopsies across the country, or in most centers, I feel.
Yeah, I would agree with you. I think that the scuttlebutt on the street from our side is basically there's some difficulty with interpretation of the cryos. And I think it depends on how the cryos are thrown. And, individuals who have really low we'll call them adverse events, but like pneumos, et cetera, that means that they're very unlikely to be getting that like very subpleural lung, because in order to sample the subpleural lung, by definition, you're usually perturbing that pleural space. But in cases where there's more of a bronchocentric aspect, and it's not about like UIP versus other, but it's about, is this organizing pneumonia? Is it HP? Is it very inflammatory? Then we are able to look and shed some light on that. And it's had a lot of utility there.
Well, this has been a wonderful session. I love the whole idea of MDD for the way it allows us to take better care of our patients. But I actually like it at my own center in the way that I get to know and work closely with people in other specialties, other departments of my hospital. And in a session like this, I also get to meet some new people and learn how to work nicely with people in other specialties at other places. So nice to meet you and work with you, Steve and Elizabeth and Leda and Peja. And I look forward to seeing you in person and officially getting to meet you the next time. So thanks everybody for a great session and for a great conference this whole week.